co-production of Oregon Public Broadcasting and Oregon Health Forum.
Major funding for Taking the Pulse provided by Northwest Health Foundation, the community's partner for better health.
Hello, I'm Andrew Holtz, and welcome to the first edition of Taking the Pulse. This is not your normal medical program. We won't be telling you which new pill or procedure to ask your doctor about. We're taking the pulse not of an individual patient, but of the healthcare system and fundamentally health itself. Why are costs going up? Who's getting care and who isn't? What are the forces of money, politics, history, and habit that set the ground rules for healthcare and health? This series is also a call to action. It's not enough to describe just what's bad or good. If we do our job well, you'll know where to push the buttons of politicians, insurers, employers, as well as doctors and hospitals to get what you want from the healthcare system and to improve the health environment for you, your family, and your community. Tonight, we begin with the Oregon Health Plan. And let's meet our panel. Dr. John Sanda directs the Office of Oregon Health Plan Policy and Research. Mike Bonetto is a senior policy advisor to State Senator Bev Clarno. Ruby Houghton is the Legislative and Public Affairs Director for CARE Oregon. John Golensky is the president of Health Priorities Group in Berkeley, California. Chuck Sheketoff is the executive director of the Oregon Center for Public Policy. Ellen Lowe is a member of the state's Health Services Commission. And Jeff Hetherington is president of Family Care Incorporated and is the executive director of Osteopathic Physicians and Surgeons of Oregon. So here we are talking about the Oregon Health Plan. Well, really, what is the Oregon Health Plan and what is it for? Well, it's to reduce the number of uninsured in our state. At least that's one goal of it. We did a survey of Oregon Public Broadcasting viewers to find out a little bit about what they know of the Oregon Health Plan. They generally think it's successful, and if they have an opinion, the main reasons are that it covers more people, which is certainly a central goal. The main problems that are identified by our viewers, that it's not covering enough people, that it's costing too much to cover each of those individuals, and that there's just not enough money to go around. But to find out a little bit more about how we got to where we are, where did it all begin? Here's a little history lesson. It began with a tragic collision of a child's desperate need and an overcommitted public purse. Little Kobe Howard was dying of leukemia. His doctors said he needed a bone marrow transplant, but Kobe was on Medicaid, and Oregon state officials had decided that the limited budget was better spent on basic care for pregnant women than on expensive and chancy transplants. Public outcry brought re-examination of the state policy and a private fundraising effort, but in December 1987, Kobe Howard died without getting a transplant. At the time, Governor John Kitzhaber was president of the state Senate.
Motion is failed. The question was, if we're going to expand the healthcare program, where should the next dollar go? And why 6 transplants instead of 60? And what was the rationale of taking people who already had coverage and giving them access to high technology medicine when you had several 100,000 people who didn't even have access to the most basic sets of healthcare services? And it became clear we didn't have a policy.
Health policy expert Dr. John Golensky came to Oregon to testify on the ethical issues of limiting what medical services the state would pay for.
The only ethical rationale for setting limits around effective medical interventions and paying for those would be if and only if that were part of an attempt to create a universal insurance scheme for the entire population.
Tickle, tickle.
Oregon embarked on a remarkable process of public discussion with hearings and polls, all to determine what's important when it comes to publicly subsidized medical care.
And they didn't debate transplants versus, prenatal care, but they talked about things like community compassion, the importance of prevention, the importance of children. And dental care got up real high, for example, because of that discussion. And ultimately, the Commission blended the clinical information with the social values that produced the list.
The list. More than 700 pairs of diagnoses and their treatments ranked by priority.
It was the first time anywhere in the world that I'm aware of that there was a process put in place to define what was provided as medical care to a population as a whole based upon good evidence and also upon the actual expressed social values of the population.
By covering only those services above a cutoff line, Oregon could afford to include more people in the system. Oregon had a tough time getting federal permission to so radically change the federally subsidized Medicaid coverage for the poor. And a proposed state mandate that employers provide health insurance never went into effect. But in 1994, 7 years after Kobe Howard died, the Oregon Health Plan came to life.
On any given year, there's about 330 to 340,000 people who get health care. We've reduced the number of kids without insurance from 21% down to about 7%, increased access to prenatal care. In the third trimester, there's been a reduction in low birth weight infants. The list goes on and on.
So how well has the Oregon Health Plan done? As you can see by this graph, at least on the number of uninsured Oregonians, it's been doing pretty well. The number has continued to go down while the percentage in the United States as a whole has been rising. So that certainly is a success story. Let's go now to the panel and find out a little bit more about how we got here and how we're doing. Dr. Golensky, I'd like to start with you. We heard you mention a couple of points in that opening segment. What generally is your view about how well the Oregon Health Plan has been in reality compared to the dream of the late 80s and early 90s?
Well, Andrew, of course, when we created the structure of the plan, we were hoping to eliminate all the uninsured to, in a sense, create universal coverage for the entire population of Oregon. So the plan has not been successful when you look at that criterion. But of course, it's reduced the uninsured rate from 18% to 11%, and that's a very measurable success.
Ellen Lowe, you're on the Health Services Commission, and first off, explain what is the Health Services Commission?
We were the ones who came up with the list.
How well do you think it's working out in reality?
I think it's done a lot for Oregonians, not only those on the Oregon Health Plan, but I think it really has assisted all Oregonians in really coming to acknowledge that health care is more than just the physical health. It's also mental health, it's dental health. And so it is assisting actually some 80,000 Oregonians who under the old system wouldn't even have had access to health care.
There have also been benefits for the particularly hospitals. Charity care has gone way down. Visits to emergency rooms. So what about for some of the providers of health care? How has the system worked out?
Well, I think the system has worked well in a couple of areas. Number one, at least in the beginning, providers were afforded cost-based reimbursement, which actually made them more willing to see patients under the system. I think the second thing that the providers do appreciate is the fact that they are coordinating the care for the patients. They're not just seeing people on a spot basis. They actually have a patient. They know that that patient is one that they're responsible for the care of, and they can direct the patient's entire care rather than just doing the episodic.
Ruby Houghton, for the members of CARE Oregon, how has the Oregon Health Plan been working out, and how has it worked out for your organization?
Well, for CARE Oregon, I think it's been a very positive move and a very positive situation. Our physicians who are on our panels, or our providers as they're referred to, like the way that we are treating them, recognizing the fact that the changes that have taken place in the market, the ebbs and flows of dollars, provide us with challenges as we move along, and we continue to work with the state, work with our providers, and work with our clients to make sure that people's needs are being met.
We haven't heard from everybody on the panel, but what I do want to do is we visited with some individuals who are on the Oregon Health Plan who get their service, and chatted with some of the providers who are dealing with it. So let's take a moment and listen to some of the things they have to say, then we can come back and talk some more about how the Oregon Health Plan is doing today.
Taking care of a sniffling infant is something David and Feliciana España know a lot about. They have 7 children. And David's job irrigating vineyards in southern Oregon doesn't include health coverage. For the Españas, the Oregon Health Plan and services at La Clínica del Valle are their only option.
Mejor con un poco más problemas, porque pues realmente el plan.
Without it, they would have a lot of problems. The Oregon Health Plan has helped them get through.
Sin él, pues estaría más.
8, 9. Oh, okay.
The Españas also get home visits by a promodora or health promoter and other services, all part of an emphasis on prevention rather than costly medical intervention. After the Oregon Health Plan took effect, the amount of charity care and unpaid hospital bills dropped dramatically, which meant the hospitals didn't have to raise prices as much for paying patients in order to balance their budgets. But in many Oregon communities, the system is breaking down. In Medford and the surrounding region, commercial managed care plans lost money and pulled out. The patients technically still have coverage, but doctors say low state payment rates mean they lose money on each visit or treatment. Mike Bond runs a physician-business partnership.
Beyond the Medicare, Medicaid, commercial insured, we also have healthcare providers in general, and certainly our physicians take a fair share of what's called charity care, where there is no reimbursement.
But take I-5 north to Corvallis and you'll find a different situation. Joanna and Michael Story are using the Oregon Health Plan to bridge a gap in private coverage.
It's been seamless, the transition from Blue Cross Blue Shield to the Oregon Health Plan. Dr. Iwanchena is on both, and so it was no problem changing.
Dr. Kevin Iwanchena says administrators in Corvallis take care of balancing payments from all the different public and private plans.
She had to play role acting, pretending that.
Differences in local economies and percentages of patients on public versus private insurance coverage all mean the Oregon Health Plan burden is heavier in some places than in others. But managers of safety net clinics who take patients no one else will accept say simply dropping that burden is not an option.
So if the Oregon Health Plan were to be gone tomorrow, there's just going to be an influx of patients coming into safety net clinics like ours saying we're uninsured, but we still need care, and we don't have that kind of capacity.
All right, so after seeing a little bit about what the patient experience is and how providers are working with the system, I'd like to go to you, Chuck Sheketoff. Your organization tries to advocate or represent the interests of individuals who may be using the Oregon Health Plan. From your viewpoint, what do you think about how well it's performing?
I think it's made great strides, as has been noted, in reducing the rate of uninsurance, but there have been some serious policy setbacks to the Oregon Health Plan. The original Oregon Health Plan said included an employer mandate, so employers would start providing insurance, and the Oregon legislature repealed that. Then because the biggest setback, I think, is the budget situation for the state. When the Oregon Health Plan was adopted in the late 80s, we didn't have Measure 5 and other budget changes. And so a lot of the setbacks to the Oregon Health Plan since it became implemented in February of '94 have been because the state doesn't have enough money. 1995, the legislature was under budget pressures, and they cut thousands of people from the Oregon Health Plan by changing some policies for how to get onto it. 96, the voters raised the minimum wage in Oregon, and that threw thousands of Oregonians off the Oregon Health Plan. Instead of raising the income eligibility for the plan, they saved the money by keeping it at 100% of poverty, and it should have been raised back then. And so it has just a number of challenges. The bottom line really is the state doesn't have the resources we said we had back when this was envisioned, and we haven't figured a way to get those resources into state government to make the plan do what it's supposed to do, and then you have the employer mandate problem.
Mm-hmm. Dr. Santa, your office is responsible for a lot of looking at the Oregon Health Plan from the administration's viewpoint and figuring out how do you keep doing what you're charged with doing. What are some of the main pressures right now? What do you think you're doing well, and what is keeping you from doing everything you'd like to do?
Well, there's just a number of dynamic factors that over the decade that the plan has been in operation have changed significantly. Currently, we're really struggling with another cycle of cost increases and how to manage through a very significant era of cost increases is going to be a challenge. This is not a plan that is really insurance in the truest sense of the word. There's a great deal of social responsibility here. The Oregon Health Plan does not have a criteria in terms of coverage that involves are you sick or not. The plan takes all comers. And that results in some very sick people being covered, and we all want to do that. But that means that compared to what many of us think of as insurance, it's much more expensive because we take all comers. We take the sickest folks and the poorest, and that's a challenge to make an operation run from an economic point of view and an operational point of view.
Mm-hmm. Jeff Hetherington, you're president of Family Care, and your organization pulled out of Southern Oregon in terms of covering Oregon Health Plan folks. Tell us a little bit about that.
Well, we actually were in we were in 3 counties. We pulled out of 2, Jackson County and Curry County. In Jackson County, we pulled out of there primarily because we were not able to operate successfully. In our opinion, the utilization in that area is far higher than it needs to be in terms of services. And so we simply could not remain financially viable, and we followed a large number of health plans that have done the same thing in Jackson County. In Curry County, it's a little bit more complicated. One of the primary physicians serving the Oregon Health Plan left the area. That left a tremendous doctor shortage down in Brookings with no physicians willing to pick up those patients.
Do you feel sometimes that the providers are being asked to shoulder a burden that is really a burden of the entire society? Taxpayers certainly don't want to pay any more, but by shorting the folks, reducing the amount that's paid so that it no longer becomes a viable business proposition, does that mean you're taking on a general societal obligation?
Well, I think physicians are asked to bear a far greater burden than virtually anybody else that does government contracting or provides services to the government. Most of the physicians now under the Oregon Health Plan are getting 45% of their actual billed charges, and that's less than their cost of doing business. You don't find any other segment of either the healthcare industry or even, for instance, if you look at food stamps, nobody else is being asked to give up that much in order to take care of a population. So I think we definitely have to do something to raise what physicians are getting paid, or they simply cannot afford to serve this population.
Raise your hands if you think prescription drug prices are a big problem right now. Oh, good. We all agree on something. That's one thing we want to talk about a little bit more. We're going to hear some ideas about what to do, since obviously money is not unlimited. That's why the health plan was started, was to stretch limited dollars as far as we could. And so we will see a little bit about some of the ideas that are being kicked around now to deal with the changes and challenges for the Oregon Health Plan.
Putting some limits on drug spending is essential, according to many.
Key thing driving healthcare costs right now is pharmaceuticals, which is really pretty shocking, but it is. A lot of people don't believe that until they see the figures.
One approach is to cover the most cost-effective drug of a certain type. Unless there was a medical reason to use a more expensive brand, patients would pay any difference. Governor Kitzhaber also thinks benefits could be tailored, that is, trimmed for some people, in order to spread the state money farther.
So I would argue that a childless couple has a different set of medical needs than a family with dependent children or a person with a disability. So we're simply asking for flexibility to design the benefit package and the subsidy based on real financial and medical vulnerability.
Since federal money is also involved, Oregon would need permission, a Medicaid waiver, to alter benefits. A waiver would also be needed for a more radical plan proposed by some legislators to dismantle the Oregon Health Plan system and use public money to simply subsidize private insurance.
This will be a graduated voucher system, so the more a person makes, the higher their premium will go, until you get to the point roughly in the neighborhood of 200% of federal poverty when the public assistance money will no longer be there.
But the governor counters that the pullout of private insurers from managed care contracts with the Oregon Health Plan shows a market-based approach won't work for covering low-income, higher-need groups. Healthcare reform is complicated and often creates unintended consequences. For instance, requiring people with some income to pay a small premium, often $25 a month. While a bargain for the sick, it's a burden for people who are poor but healthy.
What we've pretty much succeeded in doing is driving all the healthy people out of the Oregon Health Plan.
The governor has an idea to plug that hole.
One other option would be to require individuals to carry a certain level of care similar to the insurance requirement for automobile insurance. To do that, you have to make sure that there's a package available and that it's affordable.
With a tightening state budget and cooling economy, simply absorbing double-digit jumps in medical spending just isn't an option. Still, there's broad agreement that Oregon will not abandon its pioneering health plan.
When someone's house burns down, when the community rallies around them, when there's a flood or a fire, you see this coming out in people. And really, where the health plan is working, it's where those communities have been given an opportunity to engage and to take care of their own.
Ellen Woe, you're on the Health Services Commission. You helped devise this prioritized list. Talk to the people of Oregon. Is it outmoded in a decade, or do we need to revive it?
I don't think it's outmoded. I think the things that the citizens brought to us are still so very important. They talked about prevention when we went out about the state, and we did again this last year, and we heard some of the same messages. They talked about integration of mental health services with their physical health. But what I fear by going to an insurance model or by creating two very separate kind of plans, one that I might characterize as maybe a not so basic benefit plan, I see us abandoning some of the prevention sort of things that we have now, because I think behavior can change. And we're dealing with a population that has not had access to health care. And so if we can really get them involved in changing their behavior, then I think some of their future needs will lessen.
But there are a lot of folks who, especially the mood of the country seems to have been in recent years, we don't want to expand government, we want to limit government. We want to let the private sector do as much as possible. Should we just subsidize private insurance?
I think there's a misconception on the part of the public, and it's certainly driven by sometimes policymakers and others, that you can somehow make costs go away. We are going to pay the cost of health care, whether we do it through tax dollars, whether we do it through some social dollars, whether we do it in terms of cost shifting at the provider level or cost shifting at the commercial insurance level. This population is going to cost the state of Oregon for their health care about X. And the only way you can bring that cost down is to make sure you have good coordinated care and access to care. Because if you don't, and they're just tossed out in the open market, their health care costs are actually going to go up. Now, the taxpayer or the state general fund budget may not pay for it, but somehow every single one of us out here is going to pay for that cost. So it probably bothers me more in the whole public policy discussion that we sort of assume that we can make it go away, and we really can't.
We have a haves and have-nothings. We still have a lot of have-nothings. We have 350,000 people who have nothing at any one time, and 500,000 or more people who sometime during the year have nothing. And I think what we're talking about is we want to have a dialogue about identifying a vulnerable group of people who need to have. And it's in all of our best interests that they have. But then there's another group of people that maybe it's reasonable to talk about them having something. And by doing that, we could reduce the number of people who have nothing. We always need to remember there's all these people out there who have nothing. And is it fair to not do our best to spread our resources so there's fewer of those folks and make that a priority? That's what we're trying to create a dialogue about.
If you're going to take the political wherewithal to do that kind of change where you're going to incrementally add people into a second tier level, then why not do the whole population at a basic level? It's going to take the same political wherewithal. For God's sake, do it and cover the whole population of the state.
Well, I think going to a tiered thing is rationing people. It's deciding a mother with a young child is more valuable than a mother with an old child, or whatever the criteria ultimately is. And I just don't think we should be rationing people that way. And I think what we need to do in the state, the other thing that I think is really upsetting is this is a state that has an Oregon health plan. We have a salmon plan. We don't have a plan to reduce the poverty in the state.
Mike Bonetto.
I agree with what Chuck is saying, but I also think that when we look at this population, this Oregon Health Plan population, and what we have done, I mean, we all know that we have these current eligibles, which are traditional Medicaid folks that would be covered in any state. And what we have done, we have created this new group called new eligibles, and the way we have expanded the number of people. And these new eligibles of this uninsured population, I mean, really are the working poor. So I really think, and I agree with John, that it really is in our best interest, to work with employers and find out some system where we can get them some basic coverage. Right now, if they don't have anything, I mean, we're not doing them any good.
The viewers out here, what should they do? I mean, there are certain values you've been talking about. Okay, should we have different tiers? Should there be universal coverage? Should it be paid for by taxes? Should it be paid for by employers? Do we force certain providers to cut their fees or cut the costs of their drugs? How do people get involved without becoming intricately involved in every one of the alphabet soup solutions that are running around state government?
What's happened in the insurance model is we disaggregate risk depending on the segment of the population you're in, including the uninsured. And we're addressing the needs of those specific pools of people. And you get these highly elaborate plans. They have to do all this actual analysis, and it's very careful to finance it. What Dr. Santa, I think, accepting that reality, perhaps politically and financially, is doing is trying incrementally to improve the status of some of the most vulnerable populations in the state. Is that fair, John?
Yeah, that's fair.
But accepting that political reality, what I'm suggesting is if you have to accept that, then the best way to go probably is to try to improve the lot of the most vulnerable incrementally. But why not, since you're Oregon, and you've done this once before, gird up your loins and do it. Cover the whole population and create a risk pool. And stop this fiddling around with all these small risk pools.
I just think it takes the political will to do what Dr. Glinski's saying and say we want everyone to get covered.
Let's get a final word here.
Right now you're basically dealing with a minority of the population, and pretty soon you're going to have to shift that burden onto the rest of the population. And are they going to be willing to pay higher taxes for the health of the Oregon Health Plan? And I don't think so.
Thank you.
Thanks very much for joining us on Taking the Pulse. You can learn more about the Oregon Health Plan and find out how to contact agencies and policymakers involved with the plan through our website, www.takingthepulse.org. Stay with us for another edition of Taking the Pulse, focusing on employer-provided health insurance. We'll be back in a moment.
A co-production of Oregon Public Broadcasting and Oregon Health Forum.
Major funding for Taking the Pulse provided by Northwest Health Foundation, the community's partner for better health.
Hello, I'm Andrew Holtz. Before we begin our discussion of health insurance on the job, here's a brief look at some health issues in the news. A coalition of 500 Oregon businesses is trying to restrain healthcare premium hikes by cutting out the middlemen. The Oregon Coalition of Healthcare Purchasers will bypass insurance companies and deal directly with doctors and hospitals to buy care for the 400,000 employees and dependents with the companies it represents. 20 medical groups around the state responded to an invitation to take part in the plan called Patient Choice. The coalition intends to collect data on the quality of medical services so companies and employees can choose providers based on value, not just price. Sign-ups for the new Patient Choice program will begin this fall. The Surgeon General has a strategy to reduce the toll of suicide, which claims the lives of 30,000 Americans each year. That's 50% higher than the murder rate. At a Washington, D.C. news conference, Surgeon General David Satcher said it's time to break the silence cloaking suicide.
We should make it clear that suicide prevention is everybody's business. Suicide affects all demographic groups in America.
The National Strategy for Suicide Prevention is modeled on a U.S. Air Force program that cut suicide in half. It emphasizes early intervention, counseling, and other services. Oregon released its own action plan focused on youth suicide last winter. A series of public forums is continuing around the state to discuss the plan and identify local services or needs. You can link to more information about suicide prevention and schedule of the state meetings by visiting our website at www.takingthepulse.org. The number of Americans taking cholesterol-lowering drugs could triple under new guidelines. A National Institutes of Health panel recommended additional tests, and the panel produced a formula for identifying people at high risk for heart disease. The NIH urged doctors to screen their patients for high cholesterol more carefully and then help them improve their diets, exercise more, and if necessary, use cholesterol-lowering medications. The panel said many people who could be helped by these drugs aren't getting them. The Oregon Health Forum newsletter reports that the state's only residential alcohol and drug treatment program for Hispanics likely will close this summer. The 13-bed residential program is in Ontario near the Idaho border. The State Office of Drug and Alcohol Programs says it's eliminating the Hispanic program in order to boost payments to other treatment programs. The director of the treatment program claims the cut will mean Hispanics won't have an equal opportunity to get services tailored to their needs. Hello, I'm Andrew Holtz, and welcome to Taking the Pulse. If you saw our first program, then you know this is not your usual medical show. We're not here to talk about pills or procedures, symptoms, or warning signs. We take a broader view of health, looking beyond individual patients to what you might call the health environment, the forces of money, politics, history, and habit that set the ground rules for health and health care today. In our first program, we looked at some of the successes and challenges of the Oregon Health Plan. Now we turn our attention to the health coverage many Americans get at work. It may seem pretty routine, and yet health insurance as a job benefit is really an American oddity. In most nations, coverage is a social benefit. How did health insurance in this country become so closely tied to work in the first place?
Keep them on, yeah. So what I'm going to do, Sid, do you remember?
Health insurance, as most people know it today in the United States, really got its start in 1929. That's when school teachers in Dallas, Texas made a deal with Baylor University Hospital. The teachers each would pay the hospital $6 a year. In return, if they got sick, the hospital would take care of them for up to 21 days. At first, each hospital devised its own insurance plan. Then the American Hospital Association created what became Blue Cross, and the California Medical Association started Blue Shield. The Blues were owned and controlled by healthcare providers. It took a world war to get employers into the health coverage business. Workers were at a premium during World War II. However, wage and price controls barred companies from attracting employees with higher pay. But there was a loophole. Fringe benefits, including, of course, health insurance coverage, were not capped. In the Northwest, industrialist Henry J. Kaiser set up doctors and clinics, paying a flat fee per worker to provide health care. The Kaiser health plan spread, opened its doors to the public after World War II, and grew into Kaiser Permanente. Once workers started getting coverage as a routine part of employment, there was no going back.
Now let's meet our panel. Pat Hogan is a benefits consultant and senior vice president for Marsh USA in Portland. Dr. George Waldman was a primary care physician for 27 years in Central Oregon. Susan Prowse is director of health policy research at the Office for Oregon Health Plan Policy and Research. Phil Jackson is the regional director of network development for Providence Health Plans. Eric Merck is the president and CEO of InSport International, a small business in Beaverton. Lynn Marie Kreider works on healthcare issues for the Oregon AFL-CIO. And Phil Griffin is president of the Oregon Coalition of Healthcare Purchasers. Phil Griffin, I'd like to start with you. Are the ties that bind health insurance to work for so many people, are those ties unbreakable?
Well, let's put it this way. They've been there for so long that a relationship has been formed by employers with employees. And even though it may not be unbreakable, I think it would take a lot of care and thought in order to separate that relationship.
Lynn Marie Kreider, how does it work out for workers, for the members of your unions, to have their health care benefits tied to a particular job?
Well, it certainly makes it more difficult for people to eat, both in the unionized sector and the non-unionized sector, to move from job to job, because people may feel that basic needs for themselves and their families are tied up in that particular job.
Pat Hogan, you work with quite a few different employers on benefits issues. What does having this link between insurance and work mean for somebody who's running a business in America today?
Well, it's quite a burden for most employers, unfortunately, because the costs are increasing significantly. But there's also two pieces that the employer gets involved in. One, of course, is funding the benefits, paying for it. But the second piece is having to choose the benefit package that will be offered to the employees. I think many employers would prefer not to be involved in choosing what the benefits will be, even if they could just pay for it.
Mm-hmm. Phil Jackson with Providence Health Plans. You have to respond to what the market wants. If employers say we don't want to be involved in that, certainly managed care has had a big presence in the last few years. Your operation is actually moving away, loosening things up now. Why is that change happening?
That's right. There's a growing dissatisfaction, I think, amongst all our constituents. I think Pat has mentioned on the employer side, and Phil as well, that the premium increases that have been delivered in this market in particular over the last few years are very difficult to sustain. In the tight labor market that we're in, I think by and large employers have had to swallow and in some cases pass along the premium increases to their employees and family members. On the physician side, there's a growing dissatisfaction with the infrastructure and the management responsibility under managed care agreements, and we're not seeing the same kinds of results that we've seen in the past. And we have seen growing dissatisfaction amongst our members in terms of wanting better access to health care and health information.
I'd like to take just a moment to go out of the studio and visit Northwest Natural and Eric Merck's company InSport to see a little bit about the reality of health care benefits at work today.
Northwest Natural has about 1,300 employees serving gas customers, mostly in the Portland metro area. Most employees are union members who get health coverage through a union trust that the company pays into. Northwest Natural directly manages the benefits for about 500 other employees and retirees.
So what do we have here?
Well, this is what we call our Freedom Flex portfolio.
Employees choose between a couple of HMO-type plans and a preferred provider plan. The company covers 75% of the premium cost.
Close to about 12% of our operating expense, and in the case of Northwest Natural, that's right around $9 million a year.
While many employees may view benefits as separate from wages, the company considers them together as a compensation package to attract and keep good workers.
As a company, you want to maintain a good competitive benefit But you know, when costs are going up 15 to 20%, you know, you have to figure out, well, is this the best structure that we're in?
The HMO and other managed care changes of the 1980s and 90s may not offer further savings. So even large companies are looking at how shifting a larger share of healthcare costs would affect employees.
For those people that are in kind of the middle to lower middle income range, you're talking about wiping out their pay increase if you have to, as a company, transfer costs of the medical benefit off to the employee.
InSport International has only about 36 employees designing and shipping athletic apparel. But health coverage is no less important here than at a large corporation.
No, that's the only thing you're looking for. You're looking for a company which have a good health coverage.
InSport covers 100% of the medical and dental premiums for employees. Employees pay for spouses or children. But still, the cost to the company adds up to about $100,000 a year, a big expense for a small business.
Absolutely. Salaries and benefits combined are our single largest expense.
To try controlling premium increases, InSport began offering only an HMO plan a few years ago, but the price hikes continued. This year, the company switched to a new type of health coverage offered by My Health Bank. InSport pays a set amount per employee. Each employee then chooses one of 3 plans, including the HMO.
We will pay a set amount, and there is a difference between the 3 choices. The HMO is the one that we were already paying. We based our payment on that. If they choose a program that is more expensive, then they will foot the bill for the difference.
Employees get more choices and more responsibility for their health care coverage.
Very important. I think health insurance, it's hard to come by.
But how important? Increasingly, employees will be deciding by choosing what level of health coverage to buy.
As we've heard, a lot of employees do expect to get health coverage at work and prefer a company that gives it to them there. Eric Merck, we talked to some of your employees, and everyone we talked to said, yeah, that's very important for me to get health coverage at work. Is that a benefit you can continue to offer no matter what happens to the cost of health insurance?
I hope so. Meaning that I hope we can continue to offer these benefits, and I hope that there's some way to control some of these costs. Certainly, if we're looking at 13 to 18% increases per year, which is what InSport has been looking at over the last 3 years, it will become difficult.
Mm-hmm. Do you feel like you're just staying there getting hit with these things? You don't have really any influence over the prices you're being presented with?
Yes and no. I would say that we have, it feels like we have little influence, but I think in speaking with the panel that things are changing and that we will start to have some influence in the future. I can only hope.
Phil Griffin, you're with a larger company and you work with other members of the Oregon Coalition of Healthcare Purchasers. You do have a little more clout in the marketplace. How does that work? What is it that you attempt to do when you go out there to purchase health care for your employees?
Well, large companies have another benefit, though, and that is that they can deal with consultants who are experts in those areas. And as our consultants deal with the health plans and with the providers, they have a lot of information that they garner from across the country as well as from other employees in the area and employers in the area. And so you have that kind of an advantage. That helps. For a coalition to have 450,000 covered lives, which the Oregon Coalition of Healthcare Purchasers has, and bring that to bear, I mean, without doing joint purchasing, which is one of the things that we will be actually seeking this year, but going through legislative initiatives and trying to see that the laws that are being passed don't increase those costs ineffectively, and in effect, as you add on layers of legislation, you increase the cost of benefits to employers. So there needs to be care in that. So becoming involved in that through a coalition as a purchaser, even a small purchaser, is helpful. And then taking a look at the quality of what the product is that you're purchasing. And I think that's the area that we as employers need to focus more on now than in the past. And exactly what are the variations in practice. So it's those kinds of quality initiatives that I think employers as a group can really get involved in, especially when they bring in what we call affiliate members to our coalition, the health plans, the doctor independent physician associations, even some of the pharmaceuticals, to begin to bring all of the parties together at the table to say, you know, how can we control costs? How can we deliver this product in a lot more sensible way and begin to get some good standards around it?
Mm-hmm. Why are premiums going up so much now?
Boy, that's not a simple answer. I think there are a number of challenges. In the physician community, for example, in the Northwest and Oregon specifically, we are having trouble retaining and attracting physicians. The physician compensation overall is lower than the national average. And I think part of the premium increases that Eric spoke to in many respects has to do with an effort on the part of plans in this area to bring physician compensation up to a more reasonable level. We are also seeing increases in utilization in areas that we've not experienced in the past. Managed care historically focused its tools on managing inpatient admissions and lengths of stay most effectively. We're now seeing utilization increases in diagnostic services, lab services, outpatient surgery, chemotherapy, things that are considerably more difficult to manage. I think the other thing is there's greater access to information on the part of the member, or really the purchaser, consumer of healthcare today. And the historic HMO benefit designs that are very rich, I think buffered the member from the real cost of care. Over the last 5 to 10 years, if we've seen pretty dramatic increases in utilization and costs, the member has been engaged in co-pay plans where they had very minimal out-of-pocket expense. And I think it's going to be a bit of a sticker shock, as we've already discussed, when the real cost of care begins to kind of trickle out and the community at large begins to feel the impact.
Certainly giving employees a greater share of the costs and responsibilities for their own health care is a growing issue. And one form that's taking now is a new company, relatively new company in Oregon called MyHealthBank.
MyHealthBank.com is one of a handful of companies bringing defined contribution health coverage plans to smaller businesses. Defined contribution means that employers kick in a set amount per employee, and then the individual worker decides what sort of coverage to get. It's more like the cafeteria-style choices at big companies.
The employer wants to be out of that very thankless task of making a selection that's supposed to satisfy you and that person and the 300 other people who have diverse lifestyles, diverse insurance needs.
Employees choose their coverage and contact customer service on MyHealthBank's secure website.
We check these on a 30-minute basis, so getting real-time answers to their questions, or as close to real-time as possible.
MyHealthBank claims the online administration cuts overhead by more than $100 a year per patient. Fundamentally, the choice for employees is between generous coverage with higher premiums or paying a bigger chunk of basic health care out of pocket in return for lower premiums. In general, major medical expenses are covered for all.
About 60% of them are selecting the mid-level health plan, which is basically comparable with what the employers had offered the previous year. And then of the 40% that remain, about 20% of those are buying up and 20% of those are buying down.
Those who buy down tap a healthcare cash account or dig into their own pockets to pay some of the costs when illness strikes.
For the first time, you've really got an incentive to ask yourself the question, am I better off spending this $100 or $200, or am I better off saving it because my child's going to need braces in 2 years? That's a very difficult, or those are very difficult questions to answer if you don't have good pricing information.
Indeed, how is a shopper to choose when doctors often don't even know their own fee schedules and patients have no easy and reliable way to compare quality? In the future, MyHealthBank plans to offer price and patient feedback info on its website in hopes of changing the way shoppers, that is patients, connect with the healthcare market.
A lot of the changes happening now have to do with how much an individual pays out of pocket, what your exposure is to paying the actual cost for the health services you receive. I want to run through some definitions, things like co-pays you may have heard about, a fixed fee, per visit or for an item? You know, do you pay $10 or $20 every time you go to the doctor? Then there's co-insurance. That's paying a defined percentage. Do you pay 20% and insurance pays 80% of your health care? Then there are premiums. That's how much is actually paid, say, per month in order to maintain your health coverage. And there's deductibles, which is a set dollar amount you may have to pay out of your pocket before your insurance even kicks in. All these things have to do with how much you're responsible for paying before your insurance pays in, or what share you're responsible for paying. That's where a lot of the action is now. My Health Bank, we just saw a little bit of tape on that. Eric Merck, your company decided to help buy coverage through them. What is it that you saw in the My Health Bank plan that appealed to you and you think to your employees?
Choice was really the key element to it. For years we had offered a preferred provider program, or an HMO, based on the smallest increase in cost to the company, unfortunately, rather than to the best coverage for our employees. And what this company brought to us was really the offer or a choice for our employees.
Susan Prowse, you're working with the state in terms of trying to analyze all these things, the effects of cost sharing. What are you seeing? Does giving more responsibility mean better care? Or does it mean a harsher, you're on your own kind of environment? What's the reality that you're seeing out there?
Well, the literature suggests that increasing cost sharing to the individual has the greatest effect among low-income individuals.
Does it make people, does bearing more of the cost make someone a smarter shopper?
If you could control for income, probably yes. And if someone had a great enough percentage of disposable income to be able to pick and choose how they wanted to most wisely use that income.
I think there's a dearth of good information that people who want to shop and get that, places where they can go find it, they just are not there. They rely on what their doctor tells them, which is generally going to be correct, but the physician is not concerned about the cost of what's going to occur. And if the patient wants to get a non-biased opinion, there really isn't a good source for that. And I can see a burgeoning new industry coming along that will solve this. And with respect to the poorer income people, if they want to buy a car, you know, they can go to Consumer Reports, and I believe they probably do a little research before they buy a car, even if their income is barely able to afford a car. And so I think that even they, in the medical arena, could probably do with some information if such existed.
Yeah. And it's not available yet?
It's not available readily. I mean, people that have chronic disease probably are the best, most wise shoppers of that, because when you have a chronic situation, you want to know, you know, what's out there that can help me feel better, that can make me improve. And the web has been certainly, you know, a tremendous boost to that. You can go out and find even, you know, what your doctor's ratings are. I think it's healthgrade.com, www.healthgrade.com, doctor.com, about chronic disease, about disease management, and those kinds of issues.
Here is that it's the consumer that is driving the cost increase in healthcare, and I guess I would have to question that. I mean, if you look at what are the major drivers of cost increases in health insurance right now, they're prescription drugs, and probably increasingly in the next few years, the cost of physician services. And I don't think that the consumer is responsible for that.
One statistic I want to be able to throw into the discussion now is really who is spending the money. A lot of these cost-sharing things have to do with that first dollar, whether or not you go in for an office visit. They don't have to do with how much you pay for a transplant operation. I mean, it's after a couple $1,000s, usually all insurance is 100% of everything. But we do have statistics, recent research has shown that 10% of the consumers of health care account for about 70% of the cost. That means 90% of the people in the country are only responsible for 30% of the costs. And most people spend very little on health care, and a few people spend a vast amount on health care. So if you're doing all these things that are changing the upfront purchasing, and yet you're only really tweaking that 30% of costs, where does that get us? I mean, nobody's talking about stopping somebody in the operating room and saying, well, you know, you better write a big check here or we're not going to go forward with the operation. You're not doing anything to affect the expensive utilization, the big ticket items, and that's where the bulk of the spending is. So is the argument here off the target?
We're trying to be careful not to kind of throw the baby out with the bathwater. As we transition from the traditional HMO model, we want to make sure we continue to focus on the quality agenda, but also preserve that relationship between the family physician and the patient, because every study has shown that is the most efficient and effective way to work your way through the healthcare system, is establishing that relationship and having a consultant or an advocate working with you. The benefit designs that we're looking at are a lot like has been described here, where the fixed copay is with your personal or family physician and for preventive services. So we want people going in the physician's offices when they need to be seen to identify chronic conditions and conditions that need more oversight or management. Once they are identified, I think all health plans in Oregon in particular are focusing on disease management programs. This is looking at that 10%, the diabetics, the asthmatics, those patients with congestive heart failure, really looking now to manage the entire episode of care, as opposed to kind of looking at each individual office visit, but look at this patient's condition over time and really working with the patient and the physician, again, in that kind of shared decision-making role, so that the member's more active in their lifestyle choices, because an awful lot of the expenses that we're talking about here are lifestyle driven. They're also economic driven. They're also culturally and socially driven. And I think each of these kinds of programs that we put in place have got to deal with this diversity issue. We're dealing with a population that's not only aging, but is becoming more diverse over time.
However, for the average employed person, middle income and an upper middle income person, the move to a defined contribution approach may be the first time that they've ever seen the value of a health insurance plan. They've been protected in the past, so they really don't have any idea how much it costs and how much the employer has been paying of that cost.
Once people are faced with the realization that their monthly payment on their home is equivalent to the monthly payment on their health care, that's a monumental step towards, I think, the realization of what we're all facing.
Thanks again for joining us and helping us dig into at least the beginnings of some of these very complex issues. I think we can all agree that healthcare is going to get more expensive, and that we all have a responsibility for understanding what it is that we're buying and that we're getting the best quality healthcare for the dollars that we are spending. You can learn more about the future of private health insurance by visiting our website, www.takingthepulse.org. Thanks for joining us on Taking the Pulse. I'm Andrew Holtz.
Major funding for Taking the Pulse provided by Northwest Health Foundation, the community's partner for better health.